So today I'm going to speak to you about primary ciliary dyskinesia in children. I kept actually the logo of my university because if time allows, I will just also briefly touch on a part of my research that I did there in relation to primary ciliary dyskinesia. So yeah, I'll do a quick review of the history. So in 1677, Van Leeuwenhoek described the sperm movement, and in 1683, De Heide described the ciliated epithelium. In 1933, Cartagena, actually who is a Swedish scientist, described a syndrome with chronic bronchitis, bronchiectasis, infertility in men, and situs inversus, and chronic sinusitis. So he described it, but it wasn't until 1976 when Afzelius showed that Cartagena syndrome is due to immotile cilia. And initially, the terminology was that this syndrome was called immotile cilia syndrome. In 1977, Eliasson called it immotile cilia syndrome and described that it was due to cilia defects, and which led to impaired mucociliary clearance, and some patients also had infertility. In 1980, Rossman described that the cilia syndrome, they also named it dyskinetic cilia syndrome, because there was movement sometimes, but it could be abnormal movement. And in 1981, came up the new terminology, which is secondary ciliary dyskinesia, thus renaming the previous syndromes or all what I mentioned above to primary ciliary dyskinesia. That's why the name primary ciliary dyskinesia came from, because they found out in the early 80s that there are several conditions that can cause abnormality in the ciliary clearance or the mucociliary clearance due to problems in the cilia, and those were actually secondary, they weren't genetic. And I'll touch up on the causes of these secondary ciliary dyskinesia. So once they found out that there were conditions causing secondary ciliary dyskinesia, they renamed it to primary ciliary dyskinesia. So this is just a cartoon of a cross-section of a cilia. I don't know now, I'm pointing with the arrow if you can see me, like, okay. So in the cross-section, this is just brief. This is how it looks like in the cross-section of a cilium. Usually you have your 9 peripheral microtubules, and then you have the central tubules. Here, if you can see here with the arrow, these are the dynein arms. I'm just showing you these because this is where most of the defect comes, and also genetic investigations have shown these are the primary affected in PCD. And this is these are the radial spokes, these are also affected. And the next scene links. These are the primarily, you can have many defects, but I'm just not gonna go to details. So if we look at the ciliary motility, sorry, some things are popping up in my screen. Yeah, so in the ciliary motility, it's more like, you know, the whiplash kind of movement, forward and then backward. So this is how the cilia move. Any abnormality in this movement can cause abnormal mucociliary clearance. So we usually have more than 250 proteins per cilium, and the outer dynein arms are the ones responsible for the frequency, and the inner dynein arms are more for the waveform, and they both help in transportation of the mucus, fluids, and cells across the cells. There's 2 types. You have motile cilia, and there's also immotile cilia, and these act more as sensors. So the ciliated epithelium, the humans have ciliated epithelium. We have them, I'm gonna mention where we have them, because in PCD, you can have associations of problems, and this is more related to where the cilia are affected. So I'll tell you where they are, where the cilia is located. So if you have PCD, you can expect problems with this. So we have them mainly in the airways, except of course in the olfactory mucosa, oropharynx, and part of the larynx, and the distal parts of the respiratory bronchioles. We have them also in the fallopian tubes and parts of the uterus and oviduct. They're also found in the ductuli efferentis of males, and they're found in the cerebral ventricles. Sorry. And in the Hensen's node which is responsible for the flow at the back of the embryo. I'm not sure I'm seeing these things that are coming with the Zoom, but I don't know if they're blocking the slides. They're blocking my slides. Are you also trying to get rid of them?
Your slides are blocked, Victoria?
No, you know the small bar that
oh yeah, you cannot view your slide. Okay, let them take it out.
I'm moving them up and down so I can see, but as long as you guys don't see them, so it's okay. Okay, so yeah, this is a light microscope image of the airway epithelium, and you can see here where I'm moving the arrow. This is the cilia, like a ciliary brush here on the top. And the ciliated cells actually comprise 50% of the whole airway epithelium, and there's usually about 300 cilia per cell. And this is a transmission electron microscope image of a cross-section, actually, of part of the airway epithelium. And you can see the cilia here, a small little, it depends on where the section took place. So if it's more higher up and it's a cross-sectional, then you see them as small circles. Of course, it depends on the magnification. Here they look like dots. I'll take you later to higher magnitudes. And more basically, you can see if the cut came a little bit longitudinal, you can see them a little bit longer. This is more with immunofluorescent staining. You can see how the cilia look like here with magnification, of course. Yeah, so the mucociliary clearance, it can be affected by several factors. It's affected by temperature. Usually in the nose, it's about 23. These are the ideal. And in the lower airways, between 34 and 40. Any deviations from this can affect the mucociliary clearance. And then, of course, you need optimal oxygen concentration. Both too high and too low will inhibit the cilia. Certain drugs will affect, and other substances, the mucociliary clearance. Hence, these are the drugs being used to help in the treatment for the PCD. And also trauma, any kinds of trauma can affect, like barometric traumas. And then allergies, of course. It leads to increase in the mucus production and inflammation, which can affect in part of the mucociliary clearance. And then, of course, infections. Infection leads to loss of ciliated cells. So in our studies, when we were taking brush biopsies, sometimes it was a challenge to get a proper sample, because in patients that you're sending actually samples to investigate if they have PCD or not, they usually have symptoms. So that means they already have some kind of infection or inflammation. So when you get the sample, it's not representative sometimes of proper ciliated cells. You get the airway epithelium, but you can't find cells, ciliated cells. So infection also causes this impairment. So primary ciliary dyskinesia. It's a congenital disease, which is usually due to a defect in the cilia. The presentation depends on the age. Like in the neonatal period, they can present with unexplained distress. The patients who have dextrocardia or situs inversus, we have to keep in mind. And also if they're presenting with pneumonia or rhinitis, or later on in childhood, usually as these patients, they can be diagnosed as asthma for a long time before actually having the PCD diagnosis confirmed. And then that's why always it's good to keep in mind someone who is not improving and is not well in between asthmatic episodes. Same like when we think of CF, actually. Patients who come with recurrent otitis, or patients who have polyps, or then, of course, when they develop bronchiectasis. Always bronchiectasis, you have to investigate them for CF, rule out, and then, of course, PCD, you have to rule out. And in some people actually present in the adult age group, maybe they did have some asthma, which is not really picked up earlier, but then we had some patients that were diagnosed by their sometimes gynecologists for the pregnancy or ectopic, for infertility or ectopic pregnancy, and of course, infertility in males. So where does the problem, or we said it's a congenital disorder. So usually the defect is in the dining arms. And as I showed you earlier, here are the dining arms. You have the outer and the inner. And there's so many defects that have been identified that are more like diagnostic, because before, like the last maybe 10 to 50, maybe even 20 years, the shift has shifted from the diagnosis with ultrastructure diagnosis with transmission electron microscopy which was the golden standard, now shifts to the genetic testing. So before, it was all trying to prove that these cilia, there was an abnormality. And it was more about finding there's defects in the dining arms or the radial spokes or the Nixon links. These are the main factors when we make the diagnosis. There's other abnormalities, but there were more, that was mainly my field of research, they were more with secondary dyskinesia. So the inheritance is autosomal recessive, and it's extensive heterogeneity. The clinical manifestations, actually, the patient can present with persistent or recurrent cough, with purulent sputum. They can present with hemoptysis. They can present with severe pneumonia, or there's insidious onset of symptoms, or they can be asymptomatic or non-productive cough. They can have dry bronchiectasis. It can be dyspnea, wheezing, or widespread bronchiectasis or underlying COPD. And of course, with exacerbation of infection, you can have sputum volume increase and purulence or blood. So basically, the clinical manifestations, when you have someone with chronic recurrent infections, you should always think about PCD, or patients who are not controlled asthmatics, or they always have secretions. And actually, the top differentials would be the CF. You have to rule out CF and PCD. They basically, but then you have the classical triad with the PCD, which comes with bronchiectasis, sinusitis, and otitis media. And of course, if you have dextrocardia, then it's Cartagena syndrome. Not all cases of Cartagena are PCD. Sorry, not all PCD cases have Cartagena, but if you have the situs inversus, then it's called Cartagena. In physical exam, it depends what stage the patient is coming to you at. It's mainly what they have. If they're coming with infections, you will hear like bronchi, crepitations, wheezes. If it's late stages, and the patient might even have clubbing. And of course, if they develop cor pulmonale, they can present with right heart failure or hypoxemia. And amyloidosis is quite rare, actually. And I mentioned to you about the terminology of secondary ciliary dyskinesia. So this is a name given to a group of diseases, disease conditions, which cause decreased ciliary motility and changes in the ultrastructure. So it causes changes in the ultrastructure. So that was mainly our aim of, the aim of my study was to try to differentiate between the secondary and the primary when we were sent samples or trying to make a diagnosis. And this secondary is not inborn and it's not permanent. It can be reversed after treating or treatment. It's always good to know about secondary, because you need to know why they called it primary. That means always, if you have something called primary, that means there's always a secondary, right? So what are the conditions that cause secondary? Common cold, viral infections, bacterial infections, allergic and non-allergic rhinitis, especially because when we're taking the samples, you're taking mainly from the nose, chronic sinusitis, and air contamination. So when we want to diagnose PCD, it depends, of course, you're dealing with a patient. You have to have a clinical suspicion. And of course, with any patient who presents with any of the symptoms I mentioned earlier, if it's possible to do a lung function, because we're talking about a pediatric population, then they might have airflow obstruction in their lung function and air trapping. You want to rule out other causes. So sweat test should be done with someone who presents with bronchiectasis or chronic recurrent, recurrent lung infections, or always having secretions or chesty. So sweat test should be done, or even further investigations for CF to rule it out. At some point, you might think a foreign body and maybe even patient will need a bronchoscopy. Immune deficiency, especially these patients sometimes present as failure to thrive patients because they always have secretions, they always have infections. Most of them also can have failure to thrive. So part of our workup also, and with having all these recurrent infections, you want to rule out immune deficiency. So, and then I think Dr. Majid spoke to you a little bit about the FeNO, the fractionated exhaled nitrous oxide. In some centers, they have nitrous oxide screening, but in PCD and CF, we're talking more about the nasal. So if you have nasal NO, it's actually quite low, very low in PCD patients. And then of course, like I said, before the genetic came into play, it was, you need to look at the cilia function and structure. Actually, when it came to cilia function, when you take the brush biopsy, if you're in a center where you can have access to a light microscope, you can just immediately take the brush biopsy and just put it on a slide. And you can, if you just took it out immediately and fresh, you might even see the cilia still moving before, of course, the sample is destroyed. And then, of course, it will be put in certain medium and everything to be sent for further testing when it comes to looking at the structure. It has to go to several procedures to be able to visualize the cilia under the transmission electron microscope. So that's how usually the diagnosis was done. And like I said, if you're talking about a clinical patient, you want to investigate the patient as a whole. You will do X-rays. So in X-rays, it's not really diagnostic of the disease, but it will give you suspicion. If you see signs of bronchiectasis, or you always find the same infection or same findings, this patient always has problems. They mentioned like these are more findings of bronchiectasis in general, not specifically with PCD. So you can see cysts or fluid levels, peribronchial thickening, ring shadows, and which can be confirmed, of course, by CT scan, which shows bronchiectasis, or also of the sinuses, sinusitis. And in cultures, you will have strange, it's not so common to have Pseudomonas maybe in normal children, but if you do like sputum cultures or deep throat swabs, you will find Pseudomonas. Some children will have H. influenza or even MRSA. So to make the diagnosis, you will have a clinical suspicion from your history and physical. Usually it's from the history when you want to start suspecting. And then, like I said, if you have access to NO, it's quite abnormally low. And then ciliary movement, maybe it's not so common here to check the movement because most of the samples that we do here, we're sending abroad, so the sample will not be reached viable to do the movement, but it was part of the workup. You look at the ciliary beat, and then you see the ciliary beat movement. So then the main diagnosis was to check with transmission electron microscope the dynein arm defects or the ciliary defects. And of course, I can just, some centers, they thought the best ideal was to do biopsy and culture. When you take the ciliary biopsy, place it in a culture medium. Some center was doing that because, like I mentioned, you have something called secondary. And then, of course, the genetic testing. And nowadays, there are more than 50 genes that have been identified in relation with PCD. So this is a study by Jorsen in 2000, when they wanted to differentiate between PCD and secondary. They took the brush biopsies and they cultured them to see what grows. So if the new ciliogenesis, the new cilia in the right environment had normal cilia, then it's secondary because you put it in the right environment. You didn't have the causes for the secondary. But if the ciliogenesis led to an abnormal cilia, then this is definitely inborn and it's primary. And this was very difficult to do in any center. There were a few centers that can only do this method. This was part of my thesis, the study of how to differentiate between the primary and secondary. I'm just gonna, I don't know how much time I have left, if I will go into details of the study or just, okay. So I'll just quickly, so these were some of our findings that here you see that there's no dynein arms. And then this was significant that with the secondary ciliary dyskinesia, it's very significant finding statistically between the primary, it was mainly the defect was mainly in the dining arms. These were other ultrastructure abnormalities, but these were more common. They weren't statistically significant to differentiate between primary and secondary. They were more common in secondary, all the different findings such as compound cilia, as you see here, or microtubules, or the disorientation of the cilia, which leads to abnormal movement. I'll skip these. Yeah, so the genetics, there's more, the candidate genes initially, this is an article published by Omran, they were more like the dining arm in the heavy chain and the intermediate arm chain. These were the initial findings. And then they found that these genetic defects primarily played the role in the dining arms. And this was a study done on an Arabic family of 10 members, published by Omran in the year 2000. And also, like I said, these were the first genes to be identified. And then over the years, more and more genes were identified, and they will also identify which part of the defect they were responsible for, what ultrastructure they encoded for. And more studies also, all different kinds. Of course, I mean, I'm skipping these quickly because all of us, I think we are not geneticists, and maybe it will be difficult for us to just go through all the names. So yeah, this is, I think, almost my last slides. So this is the most recent study in 2021. Now, because first, when we were sending the samples, like when you're suspecting a patient with PCD, you will send for something called the non-CF panel or bronchiectasis panel. And they will check for several genes that are responsible for or were implicated in PCD. And you cannot pick up everything. So nowadays they turn to whole genome sequencing, and it's effective in cases where you can't pick up on the regular panel. It also picks up it detects structural variants. And this is good because when you do the whole genome and you find a patient who has it, and then you pick up a structural variant, you can also, it will be a novel gene discovery, and you can add it to the list. And it's also recommended that if you have a strong suspicion of a patient who has PCD, to repeat the test genetic test, you can repeat it every few years, because every year they are diagnosing more and more genes. Whatever is not picked up now can be discovered later. So the treatment, I'm not going to go into details, but it's basically, you have to try to diagnose early. Always have a clinical suspicion. Like I mentioned, bronchiectasis, recurrent otitis, or sinusitis in children, part of also failure to thrive or chesty patient, or like someone who's not improving on your asthma management. And then the main aim is basically to try to improve the airway clearance. You have to try to improve the airway clearance by nebulizers, physiotherapy, and also mucolytics. And we have to control the infection, treat the infection. And then, of course, if we diagnose early and treat the infection, we can try to, this is a disease where there is no like cure, but you can try to prevent complications. And if the patient develops bronchiectasis, you treat the bronchiectasis, antibiotic surgery, you give oxygen. Sometimes if they end up with corporal diuretics, and then ultimately if the condition becomes severe, some patients, if they have very bad bronchiectasis and deteriorating lung function, they might even end up having lung transplant. Thank you. I hope I kept with time. So if you have any questions.
Thank you very much, Dr. Eyman. That was wonderful review of primary ciliary dyskinesia.
Thank you.
Now we have the first question. What is the percentage of PCD in asthma and or bronchiectasis in general?
Actually, I had some slides, but they were mainly talking about Sweden or the European world. I didn't have figures for here, so I opted to omit them. They usually say it is 1 in 30,000, but the reality is maybe 1 in 10,000. So they're underdiagnosed. I'm talking in general, not children, in PCD in general.
In general, yeah.
Yeah.
Now, this was a discussion in the pulmonary group. Diagnosing with an electron microscopy is not available locally. So we tend to send the samples abroad. However, that will be, I think the limitations will be to assess the movement of the cilia rather than the structure. Do you know what the percentage of the movement disorders in ciliary dyskinesia, like what fraction we're missing if we just rely on just looking at the structure?
Actually, looking at the structure helps, especially if you find the defects, but also the main aim is you want to make sure you have a proper sample. That was mainly. So when you take the swab, if you look at it under the microscope, you want to know you took a proper sample, you have a representative sample that contains cilia, because your sample might not have cilia in it. So when it reaches the lab, and I think we had few patients in SKMC when I started early before we were, now I think we're more towards genetic testing. When we send them, they will say not enough cilia were present, so they couldn't make the diagnosis. So that's the disadvantage of not looking at, when we do the swab immediately, when we take the brush biopsy, you have to make sure you took some cilia with you.
That's interesting, the way you presented when you actually put it in a culture medium. That's
that one we were not doing. It was a special center, and that's actually was very advanced, and it was good to see the ciliogenesis, how it comes out. This will easily differentiate between primary and secondary.
Yeah, that's a good one. I see a lot of thank you notes to you in the chat, but I don't see any other questions. I think because it took us a little bit longer than typical, I would like to thank you very much for presenting this topic. And
thank you for hearing and for inviting me.